And I think we're ready to move forward to our next excellent presentation. We have Dr. Anand Swaminath to join us. And I'm just going to, hi, how are you today? Oh, I love your color.
Oh, I'm doing well, thank you.
It's one of my favorite
Appreciate it.
colors.
Maybe I'll be a bit bright today, that's okay.
No,
Thanks so much. I really appreciate your invitation, Christine and Andrew and Kidney Cancer Canada. I was just reflecting, this has been 7 years since I last presented at the report,
well,
and there's a lot that's happened. So
well,
I'm glad to
would,
come back and give it up.
great. Would you mind if I just did a very brief introduction? I just wanted to let everyone know that Dr. Swaminath is a clinician, scientist, and radiation oncologist at the Juravinci Cancer Centre at McMaster University in Hamilton, in Canada. And he has many clinical and research interests in the application of new technologies in radiation therapy, specifically stereotactic body radiation for a variety of indications, including kidneys. So we're actually working on a bit of a research project with Dr. Swaminath and his assistant Sam. So I'm so glad that you joined us today. I'll let you take it away, and we do have a patient that will join us at the end just for a couple of comments. So take it away. Thank you.
That's great. Yeah. So the last time, thank you again. And the last time I was here, I actually, I'm going to just share my screen while I'm doing this. The last
Sure.
time I was here, we were introducing SBRT as a concept. I remember having, not as much to say as I probably will have today regarding this technique for treatment of patients with kidney cancer. And I remember at the last forum, I had several people come up to me and ask me questions about whether or not they felt that SBRT would be was suitable for them. And I think at that time, I didn't really have a lot of answers because it was relatively up and coming. But I think nowadays we've had a lot more research, we've had a lot more experience in using this treatment. And so as a result, there is a little bit more information that I can give you in terms of when we think it's applicable in your specific circumstance. So I appreciate the opportunity to come back and talk about this today. So what are our goals for today? So our first goal, for those who may be unfamiliar with the concept, I'm going to talk about what is SBRT and why is it different than other radiation treatments. The second goal will be, well, if I have a cancer that's localized to my kidney and not metastatic, is SBRT the right thing for me? The third thing, would be if my kidney cancer is spread somewhere else. So if I have metastatic disease at this point, is there a role for SBRT for me then? And then what is the SBRT process? And many patients ask me this. So I think it's important to go over this just as a high-level overview in terms of what to expect going through SBRT and what are some of the more common side effects I may experience, understanding that depending on the situation and where you're treating, side effects may be slightly different. And then what are some realistic expectations about how well SBRT works? Now, underline the word realistic, because I think we have to talk about this a lot in context. Many of my patients who I have had conversations with about SBRT, I'm pretty upfront in terms of how I feel this is going to affect them on an individual basis. And obviously, we can go through a lot of what the statistics tell us and what the studies have told us. But you're an individual. You're going through this journey as an individual with your family and your caregivers. And so your questions may be slightly different than someone else. So I'll try to be somewhat generalized. There are some expectations that may or may not be applicable to you, but I'll try to be realistic in general. So first of all, what is SBRT? So some doctors call it SBRT, and depending on where you are in the country, some other doctors call it SABR. So SABR is known as stereotactic ablative body radiation therapy. They mean the exact same thing. So if you hear SBRT or you hear SABR, it's the same thing. What it is, it's a form of external beam radiation, so radiation coming from the outside, like X-ray therapy. And its goal is to give a very high dose of radiation to a cancer. And we typically try to achieve this in a single or few treatments. So typically 5 or less individual radiation sessions where you would come to the hospital, get treated, go home. So you may know people who've had radiation, either loved ones or friends, and more often the stories that probably you've been told is that they're given weeks of radiation. And typically it's 5 or 6 or 7 weeks, and they get a little bit of equal amounts of radiation every day. But we know from biological studies that kidney cancer cells in particular are resistant to these traditional radiation recipes. And so I think about it like you have a big tree with a big tree trunk. And if you use an X-Acto knife, you're only chipping away little bits of that tree trunk, and you're not able to chop that tree down effectively at all. But if I come in and take an axe and I hit that tree trunk 5 or 6 times, perhaps I have a better chance of knocking that tree down. And that's what SBRT is. It's taking a very big radiation dose, condensing it into a small number of treatments, versus taking a small X-Acto knife and trying to go at that tree trunk 30 or 40 times and not getting anywhere near to where you want to accomplish. So that's how I would kind of conceptualize it a little bit for you in terms of the differences between SBRT and more conventional radiation. And so for patients who have localized kidney cancer, or where the tumor is localized within the kidney and hasn't moved anywhere else, where does SBRT fall into place here? I think it's very important to understand that the current standard of care for localized kidney cancer is still surgery. So if ever I have an option of SBRT surgery or another treatment, my first pass is to a urologist. And most of the patients that I see come to a urologist first and have a discussion about surgery first. And they go through their conversation and they decide whether surgery is the right thing for them. But there are several patients that we have identified who may not be great candidates for surgery. So they either decline surgery because they just don't want to go through that process, or they're unfit to have surgery. Maybe they have some medical problems that may make surgery more high risk. So while the kidney cancer may be removable, their chances of going through a surgery successfully may be less because of those medical conditions. So then you can think about alternative options. And so SBRT is one of those alternative options you can consider. And so it may be preferable to other non-surgical approaches, because you may have heard of other approaches of treating kidney cancer outside of surgery. So you could watch the cancer, and that's a very plausible thing to do in some circumstances, particularly if the cancer is very small and not growing particularly rapidly. You could do something else called RFA, or cryotherapy. Those are forms of ablation that use a needle. So the needle goes into the tumor and either burns or it freezes the tumor. But in certain circumstances, those treatments may not necessarily be feasible for people who have localized kidney cancer. And one of the conditions where they may not be feasible is if you have a fairly large tumor. So if the tumor is more than 4 centimeters in size, those treatments like ablation with freezing or burning, they may not completely control the tumor properly. And watching the tumor in that circumstance may lead to a higher risk of the cancer spread. If the tumor is sitting next to and this is a pipe, but any sort of pipe in your body. So whether it be your stomach or your large bowel or your small bowel or a big blood vessel or your ureter or your urine collecting system, then those treatments may be at higher risk of causing damage to those structures. And you may not want to wait before the tumor grows into it before getting a treatment. So this is where SBRT may be helpful. And in particular, with respect to the localized kidney cancers, where the tumor is in the kidney itself. So if it's sitting right smack dab in the middle of the kidney, where the urine collects or where the blood vessels merge, you may have a harder time with those other treatments to effectively control the tumor and may cause more damage. So this is, again, a situation where SBRT may be preferable. So if I decide to go for SBRT, well, how effective is it? Now, 7 years ago, I would say probably, it's going to be effective, but I'm not 100% sure whether it's going to control your cancer long-term. I think that was a very reasonable thing to say. We considered it an alternative to surgery back then, but we weren't really sure whether long-term, 5, 6, 7 years out, whether the cancer was truly treated successfully with SBRT. And I think nowadays we have evidence to support that claim. So there's been a number of important studies that have been performed in the past few years showing a very high effectiveness of localized kidney SBRT. And so we're a part of a group called IROC. So Hamilton's a part of it. The group in Toronto is, there's a group in Ottawa. So we all merged together. And this is kind of led out of Australia, where we took all of our kidney cancer patients who had localized treatments, who couldn't get surgery, and we pooled our data because we didn't realize at the time that everyone was kind of doing similar things. We felt it'd be strength in numbers. So across 16 international institutions, we pooled our data. And what we found was that we were able to control kidney cancer 95% of the time at 5 years, which we thought in general was fairly good. Because remember, we're treating patients typically that have larger tumors or more high-risk tumors. So when you compare that to other modalities, our control rates, we thought, based on this, were fairly comparable and, in fact, fairly similar to even getting surgery or RFA. Although we don't advocate right now that we should replace them, we think it's a very good alternative to those treatments. And what we found as well was the kidney cancer-related death, meaning the number of patients who died at 5 years from their kidney cancer, was very, very low. And so we were fairly confident that if we are going to offer you this treatment, we think it's going to be a good option for you to control your cancer. And then this is another study out of Australia. This is the largest prospective study, so where they took patients and monitored them very closely over the last 5 years, that has shown that no one actually had a kidney cancer that came back, and no one died of their kidney cancer. This is in about 80 patients. So we're very reassured now, based on our data, compared to 7 years ago, that this is an effective treatment for kidney cancer. And I think that if it's not available to you, we have to provide, and hopefully through the support of KCC, can provide education on the effectiveness of SBRT as a treatment for localized kidney cancer, particularly in those patients who are unable to have other treatments due to other factors. However, that being said, there are no direct studies right now that have compared SBRT to surgery or ablation or surveillance. So we take a lot of this with a grain of salt, recognizing that we are treating individuals in silos, but we work as a collaborative group. So I will never offer someone SBRT without speaking to my urology colleagues. We almost always review all of our cases in a multidisciplinary fashion. So we have someone who does ablation with freezing or burning. We have an SBRT person, we have a surgeon, and we review the case and we make a decision based on what we feel is appropriate for that person in that situation. So multidisciplinary approaches to this is of utmost importance. So you may wonder, well, what are the side effects if I decide I'm going to go ahead with kidney SBRT? And so I'm going to go through some of the more common ones and some of the more rare ones, because those are the ones that can scare patients away from this treatment. But I want to reassure you that they may not necessarily be significant in the long term. So the most common side effect of kidney SBRT is you're just going to feel tired. You're coming here for 5 days to the radiation department. You have to come for about 15 to 20 minutes each day. And I'll talk a bit about how the process works for SBRT. But the whole process, coming, driving, parking, getting your radiation, that is going to cause some tiredness. And that usually is short-lived, and it gets better after a few weeks of treatment. Radiation to the kidney will cause some nausea because of what we talked about, those pipes, and they're sitting next to the kidney. So your small bowel, your large bowel, your stomach. Those can get some incidental radiation dose, although we try not to give too much of the higher doses of radiation to the tumor. This can cause nausea. And it can also cause diarrhea for the very same. In the long term, we hope the radiation will not cause damage or a leaky pipe, meaning we were not hopefully going to cause your large bowel or small bowel to ulcerate, or in the worst case scenario, cause a hole in the bowel. It is very rare for this to happen with SBRT, and only if you don't know what you're doing, you're going to get this problem. So it's important to discuss with your radiation oncologist, what are my risks of this based on where my tumor is located. And there's a very, very, very low chance that someone who gets SBRT will have to go on dialysis because of their kidney function being so affected by the treatment. And in fact, in my practice, and I've been doing this for about 10 years, I've never had anybody go on dialysis with SBRT, so I consider that a very low risk. If you look at kidney function over time, and this is a graph from our IROC group, it does show that, when you go from high kidney function, which is good, there are some reductions in kidney function on average over time, but the amount of kidney function is about 10 to 15% is what I usually tell patients. And typically that's similar to what you would see after a partial nephrectomy. So I think, and because we're treating larger tumors, we think we're doing just as well in terms of kidney function loss, even though we do see a significant reduction. And what's really important, and this is actually a scan of your kidney. So before I treat you with kidney cancer, I normally will take a scan of your kidneys to look at these functions. So this is someone's left kidney on the left and right kidney on the right. And black means that kidney is functioning relatively well. The areas of white or gray means the kidney is not functioning particularly well in that area. So you can see here that the kidney is functioning very well on the left. And this is the radiation dose in red and green and yellow that is targeting where the tumor is in that kidney. You can see over time that it slowly starts to become white, so that that kidney function in that kidney that's radiated is reduced. But what's really important to know is that while one kidney suffers, the other kidney picks up the slack. So we have data to show that if you have two kidneys, the second kidney tends to pick up the slack, even if at the beginning it may not be functioning as well. We're pretty resistant beings, so we have really good, these paired organs have a really good time compensating each other. Now you may ask the question, well, what if I only have one kidney? How is that going to affect my kidney function? And fortunately, even with radiation to one kidney, the remainder of that affected kidney tends to pick up the slack as well. So we have good compensatory mechanisms in our body to allow for changes to help offset what happens to our kidneys after the radiation. So I'm going to give you an example of someone who's had SBRT to their kidney and kind of give you a sense of what the realistic expectations are of SBRT. So this is a person who was not a surgical candidate because of their heart. And so they were found to have a 5.5 centimeter kidney mass, and it was too big for freezing or burning. They didn't want to watch it because it was fairly big, and they felt by watching it, he would have a higher risk of having his kidney cancer progress. So this is a CAT scan, and these organs at the back here are your kidneys. So this is the right kidney. So right is left and left is right here, just for orientation's sake. This is his right kidney, and this is his left kidney. This is the liver here, and these are the bowels and the stomach. But you can see here, there's a fairly large mass in the kidney, and it measures roughly 5.5 centimeters. So they came to me for SBRT. This again was about 6 or 7 years ago, 7 or 8 years ago now, when SBRT was slowly coming into practice. And we decided, okay, we're going to give it a shot. We weren't sure what the realistic expectations were. We felt that at least we'd try something to control this cancer. Otherwise, we would balance that with the risk of the cancer progressing to positive problem. So we gave him SBRT. This is a very typical SBRT type of plan. So the green blob here is that tumor that you see in the left. The blue blob that you can see kind of surrounding it is a safety margin that we put around the tumor when we map it out. And that thick red line is the radiation dose that we want to target the tumor. And all these other colored lines that are slowly kind of falling off, that represents radiation dose follow. So I consider SBRT like throwing a rock in the pond and seeing a ripple effect. You get the large splash in the middle, which is a very high dose, and then that ripple effect where all these low doses flying up. So that's what we gave this patient. And then we followed them. So typically after SBRT, we will do scans similar to what Dr. Bossier was talking about, even in metastatic disease. So we do scans typically every 3 to 6 months, depending on how patients are doing. So this is roughly about a year later after their radiation was completed. And you can see the mass is about the same size. And this is 3 years later. And you can see that the mass is about the same size. So with radiation, the tumor never grew, but the cancer never spread either. Unfortunately, the patient died shortly thereafter from unrelated causes to their kidney cancer, but their kidney cancer never spread, and we controlled the cancer. But the big question in the room is, but it never shrank away. It's there, so what's happening to these tumors? So this is the I typically have with my patients about their realistic expectations post-SBRT. When you're on treatment, you may ask me the question, well, is it shrinking while I'm on treatment? I usually will answer you by saying, no, it's not shrinking. Then you'll say, well, what's going to happen after? Will it shrink? And I may tell you, it might not shrink for a long time. And it can take even years before the tumor shrinks. But that does not mean that the radiation did not work. Okay? So if we take a biopsy of your kidney, let's say, for instance, a year after you've had your SBRT, and we look at those cancer cells under the microscope, what we notice is that the tumor is sleeping. So there are certain histological things that control something called senescence. Senescence is just a fancy term for dormancy. Tumors are sleeping. And that's what happens. Radiation kills kidney cancer. SBRT kills kidney cancer by destroying its vascular support. Because RCCs are very vascular, the blood supply gets shut off. The tumor remains intact. But eventually, they fall asleep because they're just not seeing it of that blood supply. And over time, these tumors will fall asleep, and then they will so slowly shrink away. And that's the case whether you SBRT the kidney or SBRT anything else. This is what we see. So we may tell you as radiation oncologists, it'll take time for the radiation to work. And don't be alarmed if it doesn't work right away. In fact, it may even look bigger because of inflammation from the radiation. And the tumor cells dying from the inside may make it look more like a jelly donut than it does look like a solid tumor. But radiation, be rest assured, 95% of the time, like I said, will control these tumors by creating a sense of dormancy and fall asleep. So how do I know if SBRT is right for me? So I think when you first come and meet your radiation oncologist, if this is what you're going to go through, I think it's important to ask these questions. I think it's important to ask these questions no matter who you're seeing. So how big is my kidney tumor? Where is my kidney tumor located? Am I fit for surgery based on my age and my medical conditions? And if I had surgery, how much of the kidney will you need to remove? And how will I feel and how will my body and kidneys function after surgery, ablation, SBRT? And I think those types of information are very readily available to anybody, any physician that you see who specializes in kidney cancer. They should be able to answer those questions to you fairly robustly without any sort of issue, okay? But it's also important to realize that there are multiple options. So the best choice for maybe just for you in your particular circumstances. So while I talked about averages and average reduction in kidney function and what the biopsy shows and this and that, remember, this is your journey. So you have to be aware of how this is going to affect you personally. That being said, just a mild segue, we are, as Steve said, we're conducting a survey to learn about your preferences. Now, some of you have already had your primary kidney cancer removed, or you might have had RFA, or you might have even had SBRT. So we're actually looking at what patient preferences are in terms of if you were diagnosed with kidney cancer today, what would be your preference based on certain scenarios? So we've already conducted the survey in a number of patients, but we need some more responses. So we're hopeful with your support, you can scan our QR code with your camera app, or we can provide it for you after this meeting. We want to hear what you like and dislike about 4 common treatment scenarios. So we talked a little bit about some of these. We talked about surgery. We talked about watching the tumor or active surveillance. We talked about ablation, so either freezing or burning. And we talked about SBRT. So hopefully through this survey, we can get a better understanding of what you as patients prefer. And as Christine mentioned, one of my colleagues, Samantha Sigurdson, is running this survey. If you want to speak to a physician researcher about it, the link is at the bottom and the QR code is there. You're more than welcome to reach out to me, and I'll share with you my email and Twitter handle at the end. Okay, let's switch gears a little bit. What if my kidney cancer is spread? So what are my options for SBRT at that point? And I'm going to go into 2 specific scenarios. So typically, when kidney cancer has spread, Dr. Bossier was very correct. Your standard of care is to get systemic therapy. And there are certain scenarios, though, where SBRT may be an option for you. So the first scenario is a condition called oligometastatic disease. So oligometastatic disease means my kidney cancer is spread, but it's only spread in a few areas. So it might have spread to one spot in my lung, or a spot on my pancreas, or a spot on my spine. But there's usually, on average, 5 or less spots that it's spread to. And if my kidney cancer is otherwise well controlled, like I've had a nephrectomy in the past, or I've had systemic therapy and my kidney cancer is controlled, and I just have these 2 or 3 spots, then SBRT may be an option for me. The other scenario is something called oligoprogression. So oligoprogression means I have metastatic kidney cancer. Either my primary disease in the kidney has been controlled either with systemic therapy or with surgery or SBRT. And I have multiple lesions. So I may have 12 or 15 or 25 metastases, but most of them are really well controlled, except for that darn nagging one that is growing despite my systemic therapy. And what should I do about those 1 or 2 or 3 spots that are growing when everything else is controlled? So these are 2 slightly different scenarios, but 2 scenarios where I think SBRT is an option. So we could go in with SBRT and zap or ablate with radiation those 3 spots that are present at the time of diagnosis or the time of cancer spread. Or we can go in and we can zap the 3 spots that are growing. And with oligoprogression, I tell my patients that think of it like weeds in a garden. So you have a garden you tend to, and every month the weed man comes in with his immunotherapy, his or her immunotherapy or systemic therapy, and controls most of the weeds. But you have that nagging one. So in my garden, those helicopters, they fall into the garden. In fact, this summer, we had a maple tree grow in my garden. The weed man's not going to get rid of that maple tree. So what you need to do is you need to bring back my friend with the axe here and chop that maple tree down. And sometimes with those nagging weeds, that are growing despite treatment, SBRT may be a good option in this scenario. So here's an example again. So a 69-year-old patient with metastatic RCC on targeted therapy. This time they were on pazopanib as their targeted therapy. So they started their targeted therapy October 2019. And in April of 2021, roughly 18 months later, there's a circle around this little lump here. That lump should not be there. That is a growing lesion. So they had multiple metastases that were treated and controlled with the pazopanib, but they had that growing lead that the systemic therapy couldn't take care of. So what did we do? We went in and we zapped that lead with SBRT. So what happened? 3 months later, the patient had a very good response. So you can see where that yellow circle is. There's just a little dot there. The SBRT has controlled that tumor extremely well. Now, it's not gone completely away because, remember, tumors don't tend to go completely away with radiation. They take time to go, although this is a pretty good response 3 months post-treatment. But unfortunately, at the same time, in their chest, and this is the lungs here, the right lung and left lung, and this is the middle part of your chest with your aorta and your big blood vessels, there is a lymph node sitting right there that's circled in yellow where the cancer came back again. So what did we decide to do at that point? Okay, let's try and zap this again. So we zapped this again. And then what happened was in April of 2022, so roughly a year after we did our first zap, that lymph node in the chest has really responded nicely to the SBRT. There's still a little bit of something there. Like I said, these don't go away completely. And there's a little something there. So this is great. SBRT has worked. They're on their pazopanib, but unfortunately their scans show other lesions at the throat. So in this scenario, the cancer progressed, but the SBRT gave them an extra year on that same therapy. If we didn't give them SBRT, they may have had to switch to another line of treatment. And maybe that next line of treatment was going to be effective. Maybe it wasn't. We're not 100% sure. So it's great that we were able to allow them to stay on their same therapy for a year and maybe not have had to switch to a less effective treatment. And I think this is a common scenario that we're seeing now with SBRT. I'd say the vast majority of my practice is actually treating people like this, where their cancer has progressed despite the systemic therapy, but it's only progressed in a couple of spots. So the question at the end of the day is that, well, is that 1 year of treatment, is that effective? Is that clinically effective? Do we have studies to sort of show that? Well, on average, if you look at all the studies across all the literature, even in patients not treated with kidney cancer, with other types of cancer, where they're oligometastatic or oligoprogressive, the chances are about a year. So by the time it takes the Earth to go around the sun once, is the time on average before the cancer progresses. And I would say that for patients, that's actually fairly clinically relevant. So that keeps you on a well-tolerated treatment for longer. That keeps you without having need to switch treatments. And with SBRT, which is a relatively safe treatment, I think it's, it doesn't reduce your quality of life too much. So I think in general, SBRT is desirable from a clinical standpoint. Then the question is, well, if my cancer progresses, can I get SBRT again? Can I get this question all the time? Well, it depends, right? So it depends on where the new spot is relative to the previous SBRT. So in the instance of that patient, if they developed a spot right next to that little lump in their abdomen, I may not have been able to treat that with SBRT again because I have organs surrounding it that may limit my radiation dosability. How many lesions have progressed? So if there's only one lesion, sure, maybe. If it's 6 or 7 lesions, maybe you're thinking more of systemic therapy because that's, that may be the tip of the iceberg. How well you are. So, I think that's really important as well. Can you go through this again? You've been through it once before. Are you well enough? Is your functional level good to go through another round of radiation? And how long have you been on your current therapy? I think this is most important. So if you've only been on your systemic therapy for 3 months now, but the cancer spread, that may be more of a sign biologically that the cancer is behaving poorly. And SBRT may not necessarily be the right thing for you. So I may tell you, well, let's wait another couple of scans to see really, truly, is this the only spot that's growing? Because if this is the tip of the iceberg and something shows up 3 or 6 months later, then maybe SBRT wasn't the right thing. So these are all questions that are important to ask, but they're also relevant in terms of whether or not we can get into it. So in terms of how effective SBRT is for metastatic cancer, this is my only scientific slide that I'm going to show you. So this is based on a culmination of all the studies that were put together for metastatic kidney cancer. What it showed that is SBRT controls tumors very well. So the control rate is 89%. So we're very happy. The survival, though, as you can see, that blue line kind of straddles between 60 and 100. So we're not 100% sure, like I said, whether it's right for you, right? So sometimes we do it with the best intention, but the cancer then progresses. And maybe in retrospect, that wasn't the right thing to do. But survival is variable. And I think we have to be careful when we make these decisions in terms of whether we think SBRT is the right thing in certain situations. This is one situation where it may be the right thing. So if you have cancer that's spread to a few spots and you don't want to go on systemic therapy, or you're on observation and these tumors are growing slowly, SBRT may delay the need for systemic therapy. And in some cases can actually delay it for a very long time. In this study, 2/3 of patients never needed a systemic therapy after a few years. So you can actually, quote unquote, control and maybe even possibly in a small proportion of patients here with SBRT alone. Now, I'm not saying that that's necessarily the right thing for everybody, but there are certain people that may be right for it. I think that's important to have that conversation with your medical and radiation oncologist about whether you fit that mold. The more common scenario is if you're on systemic therapy and you progress. So this is a study out of Canada that showed the longer that you're on systemic therapy, the more likely you're going to benefit from SBRT. So if you're on it for 12 months or 18 months, like my case example, the more likely you'll benefit with that year and a half, maybe even longer, of not needing to go on another treatment. So I think that from my perspective, I take all of these factors into account when I see how long you're on systemic therapy, how many tumors am I treating? You've had SBRT before. How fit are you? Those are all the things that we need to make as a decision, obviously in collaboration with your medical oncologist and yourselves, as to whether or not we think this is the right thing. So how do you know you're a candidate? I think, again, just like the early stage setting, it's important to ask questions like, how long was it before my cancer spread? How many individual metastases do I have? Sometimes you'll read a CT report and it just says there's multiple metastases. As a radiation oncologist, I count, because I think it's really important to know, does multiple mean 3? Does multiple mean 12? Like, as that really changes what we think your benefit will be from this treatment. So question your CT scan reports and say, well, how many metastases do I have? Is it too many? Where are these lesions? How big are they? And sometimes this CAT scan report will tell you, oh, for example, this lesion is this size. And that may not necessarily be the biggest one, or it may not be the one that's relevant. It may not be the one that's grown. It may be a smaller one that was 1 centimeter and now 2 centimeters is grown. So I think those are important things to ask. If I go on systemic therapy, can I get SBRT later? So maybe not now. Is the door closed, or can we leave it ajar? And I tell my patients all the time who are on systemic therapy, if the door is never closed, we leave it ajar in case we can go down the road and do it. And if I get SBRT now, will that make me ineligible for systemic therapy later? And I think the unequivocal answer to that is, if systemic therapy is offered to you, that's what you should go for. SBRT is done in conjunction. We are complementary to systemic therapy. I consider SBRT kind of like a line of therapy. So if you have first line, second line, third line, you're on second line, and then you get SBRT. That's kind of like 2.5, right? And then you go to third line treatment, because we can afford for those longer durations before the cancer progresses. So you're never ineligible if you're already on systemic therapy. You get SBRT, you're not ineligible if there's a systemic therapy down the road that's possible for you. And these decisions aren't easy. So they should be collaborative decisions made with you, your medical and radiation oncologist. So what are the side effects of SBRT for oligometastatic disease? And that depends on what you're treating. So fortunately, if it's done safely, SBRT has been safe. Few severe side effects. However, if repeat SBRT is needed, the side effects will depend on the location and the overlap with your previous radiation. And so your radiation oncologist at that point will decide if it's too risky to treat again. So what are my realistic expectations post-SBRT? Remember, the goal is not curing your cancer. The goal is to delay, control, and potentially prolong the switch or need for further systemic therapy. In some patients, yes, we may be able to control this forever, which is great. But I always have a glass half full approach when I tell folks that, your biggest risk will likely be the cancer showing up somewhere else, not the SBRT. So the balance is quantity versus quality of life. And I think overwhelmingly my patients focus on quality of life. So they have a good treatment that they're not having problems with, they're tolerating well. SBRT can add and not detract on their quality of life. At the end of the day, we don't have enough data to support the fact that it improves your length of life, but I don't think that's the focus. The focus should be like a line of therapy. Can we keep prolonging this disease? And maybe at the end of the day, for you individually, yes, that has increased your life expectancy. But as a general rule, I focus more on the quality part of quality. Sometimes your doctor won't recommend SBRT. There's many reasons why SBRT may not be on. So if you have bone pain or you're bleeding, sometimes you got to get the radiation in there pretty quickly. So palliative radiation with more conservative doses is always a reasonable option. Okay, there may be too many metastases. You may say, oh my God, I have 6 metastases, but you said 5 or less, or I have 8 metastases. How come I can't get SBRT? Maybe at that point, systemic therapy is. There's very high risk location lesions or previous SBRT in the same area. And if my original kidney cancer is still present, why isn't that being treated? Unfortunately, we're investigating SBRT in some of these scenarios. Right now, we don't have the answers for you. Maybe the next time I present a few years down the road, we will have some of these answers. But for now, I think that there are some roles where SBRT may not necessarily be the right. Okay, finally, what should I expect undergoing SBRT? Because this is important. So your first step when you decide, okay, and your physician decides, okay, we're going to go for SBRT, is you're going to get a specialized CAT scan of the cancer center. That's going to mark out the area to radiate. You'll typically lie flat on your back with your arms up. You may or may not need to lie in a device like this to keep your body still or wear a special mask or frame. Depending on the site and your kidney function, the doctor may decide to give you contrast to better see the tumor, particularly if it's in the kidney or the liver or another area where it's hard to see. Like in the lung, you have a black lung, so on a CT scan, so the tumor is pretty easy to see. You don't need to contrast that for that. But for a lymph node, you might need to. There might be special tools used if the area being treated moves to breathing, because we're not static beings. Our lungs and livers and everything move when we breathe. So we have to do specialized scans or specialized techniques to account for that. So this is what we call in the middle, a 4-dimensional CT that we take into account. So we take all the phases of when you're breathing into account when we're treating you. This is actually a special type of 4-dimensional CT where we only turn the radiation on at a certain point in your breathing cycle. So whether you're breathing in or out, the radiation turns on. And this is a device to keep your belly as flat as possible so that your tumor is not moving as much or is less moving when you're breathing. What happens after this? So once the scans are done, the radiation therapist will then put small tattoos on your skin, and then you go home. Your CT scan images get transferred to a software that us as radiation oncologists and your radiation planners use to plan your treatment. And this is an example of it. Okay, so it takes about a week or 2 to do, and we talked about this before. So this is someone with a tumor in their kidney, and that red blob there, again, is the high-dose radiation. And these are the organs we're trying to avoid. So this is your small bowel here in magenta. You can't see it there, but it's highlighted, your large bowel there. And this yellow thing is the radiation beam moving around. So that's how we plan out the treatment to show what the radiation is going to look like. And that's what you're going to experience. So you're going to lie down, the radiation machine will start here, and it'll move all the way around to your back and then stop. Okay. So your SBRT plan is ready. It gets approved. It goes through a number of quality checks and a test to ensure that it's physically doable on the radiation unit, and then your treatment starts. So this is important. If you're on oral systemic therapy, like any of the IBs, axitinib, lenvatinib, zopanib, usually stop this drug about 3 to 5 days before the SBRT because we worry about risk of toxicity and side effects if you overlap in treatments. But if you're on immunotherapy takes weeks to get out of your system. So typically we don't stop the immunotherapy. And we know that immunotherapy based on studies is safe with SBRT. Each SBRT session usually lasts about 15 to 20 minutes, depending on the location. You may get medications to prevent certain side effects like nausea or diarrhea. You'll get set up in the same position that you did during the simulation scan. And before the radiation turns on, do a mini scan known as a cone beam CT. So it's done to ensure that we're treating the right area. Then the radiation turns on. It typically moves fast around you and finishes less than a few minutes. You go home, come back for the remainder of your sessions. Like I said, typically 5 or less sessions. So this is an example of someone getting radiation, like a Lego example. But basically, this is what would happen. You lie flat, and then someone would turn on the machine, and that's the radiation treatment head that would move around you. And this is the mini CAT scan that we would take before the treatment. So it's not as nice as a regular CAT scan, but it gives us enough visualization to see that tumor in the kidney, to see the kidney itself, or to see the mass in the lung, or the liver, or the spine, wherever we're treating, and make sure we're treating the right spot every day. And sometimes that couch moves a little bit between when we image you and when we treat you. So I think I'm going to stop there, but I hope I've given you a little bit more a reflection on what SBRT is and how it may be helpful for you as a kidney cancer patient and caregiver, and some of the more common scenarios and side effects and some realistic expectations. So with that said, I'm going to stop and hopefully we'll move on with Christine and our patient representative. And this is my email address and Twitter handle. Now, just one more caveat. I don't use Twitter.
Sure.
I just use it to lurk, but you can send me a DM if you want, if you have any questions. Okay. So I'm happy to answer DMs, but I don't actually post that Twitter. Anyways, thanks.
Wow, that's wow. This has been such a great presentation. I loved your graphics, particularly the one happens
it's
next.
actually the first time I used AI generated graphics for a presentation.
They are. It's pretty amazing, isn't it?
Yeah, it's amazing.
And I love the part like you had what happens next, and you showed like what you're looking at and the radiation. You know how the radiation moves around. It's pretty amazing. And yes, I have to say, it also is amazing how far SBRT and radiation has come in the treatment of kidney cancer. You know, you said just even 8 years ago, you know, it was just the beginning, so to speak, and what we can do now is truly amazing. It's always changing.
It's funny. Most of this presentation is based on information that has been published in the last 2 or 3 years. Yeah. So we knew that we were doing something right. It just lags behind our evidence sometimes, right? And so our evidence now supports what we've been doing for this time. And I think that's really important to know and really reassuring as a radiation oncology community, that we have data to back us up at our MCCs and things like that when we're advocating for these patients.
Yes. That's great. One point I wanted our audience to, if you can, or have not already, because I know a great number of our kidney cancer community has supported, but we did put in the chat the link to the research study. It doesn't take very long. If you wouldn't mind just checking it out and answering, we'll also put it again in our next newsletter so that you could have opportunity there to link to the survey. That would be very beneficial. As you can see, the patient involvement really does make a difference in how the treatment can change going forward. So thankful to Dr. Swaminath and Sam for doing this research to open the doors even further for this kind of treatment. I'd like to introduce now Ed Faddis, who is our patient sorry, Ed, I didn't mean to do that, but Ed, our patient person that's going to give our perspective. And Ed, would you like to share a little bit? You might have a question or two, but I know that you have had SBRT, and I'm anxious to hear how it went for you.
Thank you very much, Christine and Dr. Swamanath. That was a great presentation. I came in today, I had SBRT, and I'll give you a little bit of my background. I had SBRT in July, and I had about half a dozen questions, even after I've been through the process, and you nailed every single one. So I have no questions left after you went through your presentation. So thank you very much. You know, from my perspective, I've been asked to give the patient perspective on SBRT. And it's I learned something new. I have a categorization that you've talked through in your presentation. I'm I can't say this, Ollie metastatic. My particular situation. My kidney cancer journey started 3.5 years ago. I had I was diagnosed with bilateral kidney cancer. I had a partial nephrectomy. Everything looked good, but then scans came back and I had a recurrence of that tumor in my left kidney. So I had plan to do a redo partial nephrectomy on my left kidney, but I wasn't able to. When they got in there, they determined that it wasn't oncologically safe to leave that kidney there. So I had a radical nephrectomy so I lost my left kidney. And then when we were getting ready to deal with my bilateral kidney, the tumor in my right kidney, the plan was to do RFA for that particular kidney. So I had scheduled to have radio frequency ablation on that kidney. And while we were doing the scans to prepare for that, they discovered metastases to my lung. So I had the RFA, and then on my right kidney, and then a few weeks, a month later, I had a VATS lobectomy to surgically remove the issue in my particular lung. So, my entire experience with kidney cancer was surgical, right? It was getting the tumor out of me. But then, after about a year of things looking good, they discovered I had a tumor had spread again to my left hillier lymph node area. So, at that point, it was suggested that SBRT is likely an option because that's a very tricky surgical area to deal with. So, again, you answered all the questions. You went through all the what a patient can expect from a planning perspective and how long the treatments took, and the consultations and the cross-discipline tumor boards that I obviously didn't attend, but they were described to me. And again, from a patient perspective, it was really very simple. From a I went in for that planning thing. I don't have any tattoos, but I can say to my nephews and nieces, I have some ink now. So even though you wouldn't be able to see them because they're just small. And then from the patient perspective, again, as you said in your presentation, the sessions were short. I was in and out for an hour. I had five sessions every second day, except on the weekends. The technicians were very, very pleasant, answered all my questions, and it was really a straightforward procedure. Like I said, I'm happy to take any other questions, but you answered all my questions. I had questions about side effects. I had questions about how the radiation works. I had questions about what if it doesn't control the tumor. But you covered a lot of that in your presentation. So I'm even though I came in with half a dozen questions, I don't have anything more to ask you right now. So. But thank you for everything that you've done. I think that this has been a great presentation, and it will give all the people and anyone who's going through SBRT in the future some of the things I learned and some things that I didn't even know. And so, like questions are, it was covered great. So thank you very much for this.
Thank you so much, Ed, for sharing your care path so far. Obviously, SBRT did play an important part, and you illustrate how unique kidney cancer is in each patient. Like I've learned over the years that you just never know what to expect with kidney cancer. You expect something not to work and it works perfectly, or you expect something to work perfectly and you have to make other choices. So it's a difficult care path to follow. So thank you for sharing that.
And it's also setting my expectations because I'm the type of person who's gone through surgeries. I want that tumor out, right? But you said don't expect that. So that's as long as it remains stable. And for me, it's remained stable in my last scan. So we'll see how.
That word stable is a good word. Dr. Swamanath, I know that if you can just stay for a couple minutes, we have some questions coming in the question and answer. We have a couple other that have written in. And I have one quick question. We have sometimes patients that call us and ask about a gamma knife or gamma knife treatment. Could you just compare that to SBRT? Is it the same or is it something different?
Yeah, so gamma knife so all of these types of treatment they perform similar tasks. So I gave you an example of SBRT that probably the vast majority of people would kind of experience, probably what I'd experienced, and so on. Gamma knife is a specialized form of SBRT. It's actually so if you want to, we can go back into the history books. So this actually first started as brain tumor treatment. So this initially was something called stereotactic radiosurgery. And it was actually coined by neurosurgeons. And it was first designed for patients with tumors in their brain. And the very first radiation unit to deliver stereotactic radiosurgery was a gamma knife unit. And gamma knife is a type of unit that gives very, very high dose, same thing that we would do with our traditional radiation units, but it's a specialized unit, and it's typically for brain tumors. So someone may have had their kidney cancer spread to their brain and be a
Mhm.
candidate for radiosurgery. I didn't get into that too much because that's a
Yeah.
little bit different than SBRT, what we've been talking about. But radiosurgery is a very common treatment for patients with brain metastases across the cancer spectrum, whether it's renal cell cancer or other cancers. But for kidney cancer in particular, once it's spread to the brain, I would say the standard of care is to get radiosurgery. And Gamma Knife is just one way of doing that. There are other machines that do it. So you can do it on a regular radiation
Mhm.
machine, like the ones we use for SBRT. There's a machine called CyberKnife. You've probably heard of that, or
Yes,
some patients
yes.
may have reached out about that. That's another machine that gives radiation to the brain. They're all unique in how they do it, but the goal is pretty much the same. So
Okay.
we're really trying to control the cancer. We're trying to do so at a high level, and trying to keep people on the same treatment that they're on. And or in the setting of oligometastatic disease, where maybe it's the only spot where the cancer is spread, right, in
Yeah.
the brain. It's an effective treatment for that, and it controls the cancer. Maybe the patient can be off systemic therapy or not require systemic therapy for some time. So the principles are similar.
Okay, very good. I think Mona, you have a question.
Yeah, a question actually that came out on from our coffee chats, of course. A patient who has had a stable tumor in her imaging over 2 years. She's wondering if it's a dead tumor.
Yeah. So what I usually say to those is that the tumors, like I talked about in the presentation, radiation causes these tumors to fall asleep. So they radiographically can look very similar a year, 2 years down the road. So what I usually tell patients is that they're in dormancy. They're not doing it. They're not actively dividing cancer cells. So when you look at, you can see biopsy specimens pre and post SBRT. What you notice is those cancer cells are present, but they're not actively dividing. So I would usually say that the cancer is dormant and it's not doing anything. And that can be the case, and eventually the cancer will start to shrink. And sometimes I have patients where their cancer takes 2 to 3 years to shrink before objectively on a CT scan. So it could be 4 or 5 centimeters for 2 years, 2.5 years, and then all of a sudden it becomes like 3 centimeters. And I used to be worried initially that the radiation wasn't working, and even urologists who I worked with were worried as well, and rightfully so, right? Like, how do we know how this is working? Because but kidney cancer just reacts differently to SBRT.
Yeah.
We figured that out through a lot of painstaking experience and research, but we know now that if it's not changing inside size, it likely means that the SBRT is
Great. Thank you. That was a really good answer. And actually, this question kind of leads into exactly what you've just talked about. This particular patient has had SBRT 3 times, and she does comment that it was very easy all 3 times. It was a good experience. But one of the tumors has woken up, so to speak, after 8 years. Is this common, and do we have long-term data, or,
That's a great question. I mean, that's why our control rates are never 100%, right? So
Right.
when we look at our control rates with SBRT, we talk about control rates of 90, 95%. There's unfortunately going to be those handful of times where the cancer will grow. And I've even had that experience in my practice as well, where despite our best intentions, the cancer will grow again. And sometimes, one of the things that I think is important to understand is that because of our advances in systemic therapy, I mean, Dr. Bossi was talking about line 5 of therapy, patients are living longer now. And so, that's a great thing. But it also can mean that the length of time that you see after you've had a local therapy may be enough time for the cancer to grow back. And so as a result, yes, that can happen. Our data doesn't go out on average to 8 years just because, the data that we have is a little bit more immature than that. We're talking about 3, 4, 5 years in terms of how effective the SBRT is. But there have been late recurrences, just like there's late recurrences after surgery. I've seen people who recurred after 20 years, their kidney cancer is. And so sometimes the biology of this disease just astounds me. It can be very fast. It can be exceedingly slow. And it's like you said right at the beginning, it's so variable how it affects individuals differently. And I think that on average we do pretty well, but it is those handful of situations where unfortunately, sometimes it does happen. And then the question is, what is the option then? And it all depends on the scenario in which you're dealing. is that now something you can remove? Is it something you can do maybe another type of ablative therapy? But those are the questions that need to be answered based on that specific scenario. But yeah.
Okay. Thank you. I'm sorry we've kind of cut into all of our break time, and I do want to allow our patients to stand. There are a couple of questions in the question and answer, Dr. Swaminath, if you wouldn't mind just typing an answer. One's in regard to the, radiation content, and one's in charge to lighting up on a PET scan if it's dormant. So those are two important questions, and we can all check in the chat for those answers if you wouldn't mind doing that for us.
Sure. Yeah, we'll do.
And I have to say thank you so much. This has been so informative, so helpful to our patient community. Excellent. And we'll look forward to getting you back in a couple of years to update us on the changes. I do appreciate all your support, because you're one of my go-to doctors, and it just speaks to our patient community. I want to let you know that Kidney Cancer Canada is blessed by the support they get from their medical community. And Dr. Swaminath and Dr. Basse and the rest of the doctors that you're going to see today, they are very giving of their time and expertise, and we just are so grateful. So thank you for joining us today.
Thanks very much. Appreciate it.
Thank
Again,
you very much.
you guys do excellent work, and
thanks,
it's
Ed.
a pleasure to be involved in this. And thank you, Ed, for your sharing your journey with us as well.
Thank you. Yeah, Ed, thank you so much. We're just I know we're running behind, and I apologize, but I think it's important if we all just take 5 minutes. We're expecting Dr. Keneal to give an excellent session on ESMO results. I know there's a lot of really great highlights coming out of that meeting, but just 5 minutes to stand, stretch, bio break, or get that glass of water or whatever you need. Just 5 minutes, please. And then Dr. Keneal, I beg your patience. Thank you so much.